Welcome to another edition of Cracking the IR Code. I am Stacie Buck, President and Senior Consultant at RadRx. So it has been a little while since I've been with you. I had a very crazy month of June with a lot of different projects going on and working on some exciting things. But now I am back during the month of July, and hopefully I will be able to get you a case study here on YouTube every other week. That is the goal that I am shooting for. So for this particular case study for this week, I chose one for cerebral and spinal angiography because I often see that coders struggle with these cases, but I really feel like sometimes there's this overthinking that occurs with them, and I don't think they're really as bad as most coders think. Obviously, there's a lot of vessels that we're coding for when it comes to spinal angiography, but really the coding is very straightforward. So this particular case, we have a 58-year-old man who developed progressive weakness in the lower extremities. He has symptoms of being paraplegic and incontinent, had a prior MRI. There was enlargement with edema of the spinal cord, and so there was a possibility of an AVM. So it is recommended that the patient has cerebral and spinal angiography to evaluate these findings. So this is a patient that is just having imaging. There was no intervention performed. So we know that we are going to be looking at the imaging coding as we go through this report. We don't have to worry about the coding rules for diagnostic angiography in conjunction with therapeutic interventions. So first we see that summary of the procedures performed. We see all of the cerebral angiography that was performed. We also see all of the spinal angiography that was performed. So that list is helpful in evaluating coding, as we know from past cases, but we always want to go and look at the detailed findings in the report, and that's where we're going to get our codes from. So I'm going to go ahead and jump down into the case itself, the steps of the case. So we see initially under discussion that access was obtained to the right common femoral artery. So hopefully by now, by watching past case studies, you realize that code 36140 is the code that we start with upon initial access. But once the catheter moves out of the extremity into the aorta and then vessels beyond, that 36140 is going to be bundled with that additional catheter work. So what happened here is the catheter ended up going from that extremity puncture to the abdominal aorta and then the thoracic aorta under fluoroscopic guidance. So then from there, we're going to jump down to the next page where we actually start to see the detail of the catheter placements and the imaging. So in the first part of the report, we have the cerebral angiography. So we see the catheter was moved to the right common carotid artery, and then contrast was injected. And then we see findings for it says there are findings for normal contour of the vessels and origin of the internal carotid artery without evidence of stenosis. The catheter was then advanced into the right internal carotid artery. So notice with that first step, with that first catheter placement, we have a 36223, which gets dropped when we move along to the 36224. At that point, the reason why we had a 36223 was because the catheter was only in the right common carotid artery, and the internal carotid artery was evaluated from that contrast injection. So if the catheter hadn't been advanced any further, that would have been the code. But the catheter actually got moved further into that right internal carotid artery. So now that's going to change that to a 36224 with the catheter being advanced further and then an imaging occurring again of that internal carotid artery. So we have 36224 on the right side. Then we see the physician place the catheter into the right external carotid artery. And then it says injection of contrast, demonstrated normal contour of the vessels. So to assign 36227, the catheter has to be in the right external carotid artery, which we have, and we also have findings for that vessel. That's a 36227. Now, when we jump into the third paragraph, we see that the catheter was used to select the left common carotid artery. There was an injection of contrast for the common carotid and the origin of the internal carotid. So again, similar to what we saw on the right, we start out with a 36223, but then the catheter gets advanced into that left internal carotid, which changes that 36223 to a 36224. So now we have a 36224 on the left. So on the file here, I left out the LT on that 36224. Now, regarding the modifiers, when we're talking about, coding for the head and neck, I will say that some payers want modifier 50, some want RT, some want LT. So you'll have to look into that to determine which ones you should be assigning based on the payers, because there is variation there. And then we jump down to the next paragraph. We see that the catheter was placed in the left external carotid artery, contrast is injected. We have findings. So that also is going to be a 36227 on the left, just like it was for the right. Then we also see in the next paragraph, the catheter goes to the left vertebral artery. We have findings documented. And then we see that the catheter also goes into the right vertebral artery with findings documented. So code 36226 requires that the catheter is placed in the vertebral artery for vertebral artery imaging. And that is exactly what we have. So now let's jump down to our spinal angiography coding. Okay. So here in the spinal angiography section, in the first paragraph, we see mention of the catheter being placed into the right and left supreme intercostal arteries. Okay. So I'm going to kind of hold that for like the moment. And and it's the same with the second paragraph, where we're talking about the right and left T4 intercostal artery. I'm sorry, we're going to jump down to that, the T4 intercostal artery. So hold paragraph 1, and we're going to come down to the actual spinal arteries themselves. So what we see here is right and left T4 intercostal. Then in the next paragraph, we see right and left T5 intercostal. Then in the next one, right and left T6 intercostal, and then right and left T7 intercostal, and so on. And that actually is going to occur, that same verbiage is going to occur all the way down to the level of the T12 intercostal. So with the T intercostals that we're seeing here, each one of these is a branch directly off of the abdominal aorta. So they're going to be their own vascular family. So then that means that you are going to code for each one of those vessels separately. So we are going to assign code 36215 for the right T4, and then 36215 for the left T4. And then likewise, as we go down the list, 36215 for the right T5, 36215 for the left T5. And so we're going to follow that convention all the way down. And then you'll see the imaging is 75705 for each intercostal artery. So for each thoracic artery that's being catheterized, 75705 will be assigned. Why do we not use the add-on code 75774? Because each one of these vessels are their own separate vascular family directly off of the abdominal aorta. The only time you're going to use code 75774 with a spinal code, with the spinal imaging code, is if there is an additional branch selected. So for example, if the physician had selected that right T4, did imaging, and then advanced into an additional branch of the T4, then you would have 75774. But each individual spinal artery is always going to be coded with the 75705 code. Then we jump down to, I'm going to scroll down to where we get to the lumbar arteries. So now we have the right and left lumbar arteries being catheterized at the L1, L2, and L3 levels. So our imaging code does not change. Spinal artery coding is always going to be the same. Where we see a difference in coding is the catheterization coding. Why is that? Catheterization coding. Any vessels that are above the diaphragm are coded with 36215. So all of the thoracic vessels are above the diaphragm. And then any vessels below the diaphragm are then going to be coded with 36245. So that's why we see the difference in code. However, note the same coding convention applies. You assign the code once for each individual artery catheterized, and then we also have the imaging code as well. So now I'm going to jump back up to that first paragraph where we see the right and left supreme intercostals being catheterized. So these vessels actually are coming off of the other vessels that are in the upper extremity. So if the physician's advancing the catheter, he's actually going through the subclavian artery, okay, on the right or on the left, and then you have multiple branches that come off of the subclavian on both sides. So you may recall, I don't have a drawing up on my screen, but we have a right thyrocervical trunk that comes off the subclavian, or a left thyrocervical trunk. And then we also have a costocervical trunk as well that is going to come off of the subclavian. So these intercostal arteries are actually going to come off of those additional vessels, okay? Now, they're going to be third order vessels. So the question is, if they're third order vessels, why are we using 36218? Because we've coded all first order vessels, correct? Well, this ties into the cerebral angiography that we did above, okay? So whenever you assign code 36226 for vertebral imaging, whenever the physician goes and catheterizes those additional vessels, either the thyrocervical trunk or the costocervical trunk, when those are catheterized or branches of those are catheterized, you're going to use code 36218. That occurs when you've assigned 36226 for vertebral imaging. If you have not done that, then it would be appropriate to code with a 36217. So that is one of those odd rules, coding oddities, if you will, that comes along with coding the 36226 code versus when you don't code the 36226 code. And that actually, if you go and look in your CPT manual and read the instructions for codes 36221 through 36228, you will actually see that instruction about using those codes, because normally it's not appropriate to use 36218 with your cerebral angiography codes, but there is that one scenario. And then you'll see for imaging, notice for imaging for the right and left supreme intercostals, I still noted 75705 times 2. Now, some may say that those should be coded with 75774 times 2 because we used 36218, and normal convention would be 36218 in the setting of using the 36226, that we would use 75774 for those vessels. That is correct. However, because the right and left supreme intercostals were injected to evaluate a spinal indication, that is why I went with code 75705 for both the right and left supreme intercostals. So let me scroll down and we'll do a little review of what we have here in summary. So our final codes end up being 36224 with modifier 50 for the bilateral internal carotid angiograms, or RTLT, depending upon your payer. 36227 modifier 50, depending upon your payer, could be RTLT. Actually, CPT guidelines say that it would be times 2, not modifier 50, to mention that. And then 36226 modifier 50 for bilateral vertebral angiograms, again, maybe RTLT, depending upon your payer. And then for review, we assigned 36218 for both the right and left supreme intercostals, because we had already assigned code 36226 for the vertebrals. So that's going to change those branch vessels to the add-on code. And then we have catheterization of all of the thoracic vessels. Those are all coded with 36215. All the catheterizations of the lumbar vessels are going to be coded with 36245. So that gives us 18 36215s, 6 36245s, and then we have a total of 75705 for 26 times. Now, again, as far as billing is concerned, you may, depending upon payer, be billing the total number of units for these codes. You may be doing the initial unit on one line item and then the additional units on a second line item with a modifier. So that's something that you will probably have to take a look at payer by payer to see how to best submit these claims with all of these different units, whether it's separate line items using NCCI modifiers or it's using the total units. So again, I'll just go through the comments. The catheter was initially placed in each of the common carotid arteries for imaging. So the catheter was ultimately advanced into the bilateral internal carotids. So we ended up with 36224 with the lesser order imaging being bundled. We also had 36227 where the catheter was placed in each of the internal carotids on both the right and left. So we were able to assign that. And then the catheter was selectively placed in each vertebral artery for imaging as described by 36226. And then again, the 36218, we used that because the add-on code 36218 is reported for catheterization of vascular beds in the head or neck and or the shoulder girdle when performed in the same session as vertebral angiography. That is actually the language that I mentioned that is in CPT. So that is why we did that. And then we have 36215 for each thoracic spinal artery catheterized, 36245 for each lumbar artery catheterized, and then we have 75705 for all of the lumbar, all of the spinal arteries and also the supreme intercostals. And I didn't leave a note on here that there are some differences of opinion on how to code the supreme intercostals. So hopefully this example will be helpful to you. You can hold on to it for future reference, and you can be coding these spinal cases like a pro. Talk to you again soon.